we are going to move on to talking about the realities of long-term treatment, managing the chronic effects of TKIs, chronic complications, and other challenges. And Ephrem will be bringing his two cases from his work in Ethiopia, and Gianantonio will be discussing them with him. Ephrem, are you able to share your slides now? And I'll just say as well, if you have questions, then please drop them in the chat and jump in the discussion of the cases at the end. And to be clear, if you would like to ask your question in French, that is absolutely fine. Please do so. And everybody who would like to hear that in English, if you use the interpretation button at the bottom of the screen as described at the beginning of the presentation and select English, then that's absolutely fine. And we can have questions in both languages. So without further ado, let me hand over to Ephrem and welcome you. Thank you very much, Ephrem, for coming in and bringing these cases today.
Thank you very much, Amanda. Can you hear me fine?
I can hear you just fine. Just speak nice and loudly and clearly.
Okay. Thank you very much. Good morning, good afternoon, good evening, everyone. And I would also like to extend my warm welcome for everyone to this International CML Foundation Regional Key Discussion on CML. I'm Dr. Ephrem. I'm an internist and adult clinical hematologist practicing here in Ethiopia. And I'm going to be discussing on the long-term realities that we actually face in managing CML over a long period of time. And later on, I'm just going to be bringing on Professor Gianantonio to reflect on the two cases that I'm going to bring to reflect the challenges that we face in our part of the world in managing CML. Just to say a few words, more than half of CML patients were estimated to be living in resource-limited setups, so the prevalence is increasing. And the CML, particularly in our setup, is the most common chronic leukemia, followed by CLL. And following the introduction of imatinib, just like the scenario everywhere, the outcome of patients was significantly revolutionized. And in our setup, we have diagnosed like more than 2,000 patients in our center, and they were enrolled into the GPAP program, which is supplies the tyrosine kinase inhibitors to our setup. So our patients are quite young compared to the Western setup. Median diagnosis is 34, 39. In our particular center, local study showed median age is like 37 to 34, and more than 65% of our patients are diagnosed less than the age of 40. So we have quite young population group CML. We can imagine the economic and social burden that it implies. We have a local CML foundation, which was established more than a decade ago, which provides information, creates awareness, and provide financial and psychological support to our patients. It really helps. And currently we have access to all the second and third line BCR-ABL tyrosine kinase inhibitors to use in patients at the time of imatinib resistance and intolerance. As opposed to patients that relatively older patients that you see in the Western setup, majority of our patients are young and well tolerated. Majority of the TKIs, we don't see much of systemic dysfunction, organ dysfunction that interferes with the long-term CML therapy. So the problems that we face in our part of the world are quite different. So these are some of the local challenges that we face in managing CML over a long period of time. We don't have easy access to diagnostic and follow-up investigations, diagnostic PCR-ABL, FISH, and the PCR tests are not quite available in government hospitals. And at the time of imatinib resistance, then the kinase domain point mutation analysis is also not available, it's barely available. So the choice of second, third line TKIs is usually following the best clinical judgment of the hematologist. We have adherence issues in our patients. Significant number of patients tend to discontinue or have interrupted treatment. Some following for a few months of administration, when they feel fine, when the spleen goes away, when the white cell count improves, they tend to discontinue therapy, and most because of the economic burden and transportation issues, we have a significant number of adherence issue in our setup. And decentralized CML care is also an issue in our setup for a country of a population more than 120 million, and the surface area like more than 1.1 million in kilometers square. We have only single CML treatment center at the moment, which is located like in average more than 100 kilometers from the peripheral cities. So it's a very problematic issue for patients' adherence to treatment. Attempts are currently being made now to decentralize CML therapy for our patients, but until then, we are facing quite a trouble in that area. We have also the economic burden that I have just mentioned. Significant number of our patients present very late, so they tend to have disease progression, resistance quite early, and more than 75–80% of our patients at presentation have high so-called risk score, and they tend to progress early and they will have resistance. That's also an issue. And for this group of patients who tend to progress to advanced stage and tend to have resistance to more than one TKIs, where the standard of care elsewhere is stem cell transplant, we don't actually have that service, and that's quite a trouble. And that area, our surveys are quite suboptimal. So these are some of the major local challenges that we face, and there might be something different from the things that we face that's in the Western setup. But these are the problems that we face, and the two cases that I'm going to bring are quite reflecting these challenges. So, audience who are just joining, please make sure to mute your mics. It's interfering with the presentation.
I think that might actually be Gianantonio's dog that you're hearing there, Ephrem, in the background. But maybe, okay. Gianantonio, do you have any comments to make about the context that Ephrem has set out before he goes on to his first case?
I was reasoning on that. Imatinib is a wonderful drug, but you need other tools to let imatinib be successful. And my fear, and is shared with Ephrem's fear, is particularly a lack of tolerance and a lack of adherence to the treatment, because going not frequently to the referral center, not seeing the doctor, not seeing results in younger patient population frequently is translated into a lack of good adherence, and this is no doubt is a problem. But I guess that with even a single referral center, for example, in Ethiopia, with a good system to interact digitally, electronically, with a doctor with experience like Ephrem, will probably ameliorate. And it's probably even one of the endpoint of the foundation, International Similar Foundation, giving support from Europe, for example, from myself, for example, to solve a clinical question difficult probably when the infrastructure of the nation is not ideal to promote interaction locally with doctors. So it's challenging, but I see that Ephrem, from the cases I already saw in advance, is fighting properly to ameliorate the situation there.
Super, thank you. Ephrem, back to you for your first case.
Okay. So the first case I have for today is in a 46 years old male patient who was diagnosed with CML, chronic phase, which is a decade ago in 2014. And we started him on imatinib. He achieved complete hematologic remission by the third month of therapy. And follow-up adherence was quite fine till the 6 months of treatment. Then he started to develop moderate to mild moderate degree of neutropenia, and subsequently had absolute neutrophil counts to the level of 700. And imatinib therapy was discontinued a few times because of this hematologic toxicity. But in most of the times, we kept him on 400 milligram daily dose of imatinib for 6 years till the year 2020. But subsequently, his neutrophil count was progressively it was deteriorating. He had records of absolute neutrophil count to the level of 500. The other cell counts were fine, but he had recurrent multiple moderate degree of neutropenia, and treatment was quite interrupted multiple times because of this. We did the bone marrow aspiration, and he had trilateral hematopoiesis. Cellularity in the bone marrow was quite fine. And there was no sign of disease progression because the patient was still in chronic phase. And the BCR-ABL showed complete cytogenic response, and the BCR-ABL was less than 1. And he was doing well in terms of the cytogenic control, but he had persistent degree of neutropenia. So we were not able to continue treatment with imatinib. He had chronic hematologic hematinic intolerance. And after like 6 years of therapy, we were obliged to change the treatment to second-line tyrosine kinase inhibitor. We started him on nilotinib, and 400 milligram BID dose was started. But despite the shift in therapy, the cytopenia actually worsened, and he had ANC recurrence to the level of 400, multiple recurrence. And in fact, he also started to have thrombocytopenia. And multiple treatment interruptions were there, and we are appointing him like every 1 week, every 2 weeks, and he was coming from a very far area, and he was not able to cope up with these frequent hospital visits, and he was lost to follow-up then for 10 months. And he came back after 10 months, and actually the CBC profile was quite fine at the time of presentation. Then we restarted the nilotinib therapy, and again, the cytopenias actually recurred again. And he had similar degree of significant neutropenia. He also had mild thrombocytopenia also. Again, we repeated the bone marrow this year, and still has the bone marrow. There is no sign of disease progression, and the blast is still 1%. The cellularity was fine, and he was actually close to deep molecular remission. The response was quite fine. And we tried to add folic acid into the treatment, but was not helpful, and still had chronic intolerance, hematologic intolerance to the nilotinib therapy. And we decided to change the treatment to dasatinib for the hematologic intolerance. But unfortunately, after introduction of the dasatinib, after just a single dose, he developed a moderate hypersensitive reaction, which was characterized by diffuse skin rash and also swelling edema of the lips. But he didn't have any significant respiratory symptoms, shortness of breath, and like that. He had a moderate degree of hypersensitivity. Dasatinib was, in fact, discontinued. And the CBC profile was fine. And currently, we saw him this month, and we are attempting to reintroduce dasatinib into the treatment. We gave a few more doses, and the reaction actually didn't come back. And we are trying to reintroduce dasatinib into the treatment at the moment. And the CBC profile is fine. So this is all about the patient. It has been quite right in this patient. And we feel free to raise any point regarding this patient, but there are a few points I have identified from this patient, like tackling chronic intolerance to multiple TKIs in these resource-limited setups is quite a challenge sometimes. So the way forward is sometimes difficult. And in fact, treating patients at a lower dose of TKI, second subgeneration TKIs can be suggested, but like with the lack of a close cytogenic molecular response, that's also quite a challenge. And that's the other thing that I picked from this patient is the role of decentralized treatment. Like this patient wouldn't have discontinuation of treatment if you had a follow-up nearby hospital. So these are some of the issues that we repeatedly see in our center. That's why I brought this patient for discussion. So that's all about the first case, and you can jump in and comment on any of the issues that I have just raised. Thank you.
Thank you, Ephrem. May I ask you a question? The body weight of the patient at the beginning of the treatment, you remember? No, roughly, it was 50 kilos, 45 probably at the moment, or you don't remember?
Yeah, the patient, he had quite an average body weight, which is around 55 to 60 kgs. His BMI was normal.
Okay, 55, 60. This is an unusual case for me, at least in my experience. A responsive patient like this one is generally not suffering of cytopenias. When you have recurrent cytopenias, frequently this is a flag of a resistance answering, but this was not the case. The case of a young man with a chronic cytopenia, not dangerous, but anyway, he came down to 500 neutrophils, and so this case probably can open the discussion about dose adaptation. No, once the patient was sensitive to the treatment because he was in complete cytogenetic response at the end of 1 year. Probably the management would be better in the sense of dose reduction of imatinib, like 300 milligram. Generally, hematological toxicity is called hematological intolerance. But once more, hematological intolerance can be translated in a resistant disease when the patient is showing recurrent episodes of cytopenia, and you perform a bone marrow examination and 100% Philadelphia polychromosome. This is one form of really tough resistance. But this case was totally different, sensitive, but with chronic cytopenia. So looking back was more probably my treatment strategy would be to reduce imatinib to 300 because you tried to give him nilotinib, which is, I agree, far more selective than imatinib. So it's more active, producing less cytopenias. But in this case, the dose was probably too much for a patient already responding. But anyway, you try to give the best treatment at the ideal dose. And now we have a patient with a long history of CML and on dasatinib, and you are thinking to restart dasatinib. And this is probably a good idea, but probably the dose of dasatinib ideal in that patient would be 50 milligram and not 100. So I never would suggest to go back to 100 because too much for a patient already in good response. This is my interpretation, but Ephrem, I was thinking to my long experience, and I post you a question now. How many times you encountered patients responsive to the treatment, so in good response, in deep response, in complete cytogenetic response, with a chronic relevant cytopenia? Or was the patient had splenomegaly independent from CML for other reason, for a previous infection or so on? Because it's really unusual to see a patient like this. You know, 100% of the patients, in my experience, once they achieve a response, after that, cytopenia is no more a problem, and patients have more or less normal blood counts.
Yeah. As you have rightly said, Professor, we don't see this kind of cases quite often, the same as your experience, but we see patients from time to time, patients having these features of chronic intolerance to like one or more than one TKIs while having a good cytogenic or response. And sometimes we end up decreasing the dose of imatinib or the other second-line TKIs. But as you have rightly said, these recurrent cytopenias that we usually notice in patients having signs of like disease progression or imatinib resistance. And usually when the BCR availability is quite good, usually we look into alternative causes why this patient would develop cytopenias. Like, could this be nutritional causes, which are quite common in our part of the world? We tend to look for features of megaloblastic anemia. In older patients, we try to look into possibility of like MDS or other hematologic malignancies. Features like portal hypertension with liver issues, having thrombocytopenias. So these are the kind of things that we usually look into if you have this degree of chronic cytopenia, despite having a very good cytogenic or molecular response. But such kind of patients are not quite rare in our setup. We see patients from time to time having good cytogenic molecular response, but recurrent cytopenia, especially neutropenia and thrombocytopenia. So they are quite a challenge. And decreasing a dose for this group of patients, we need to be able to closely monitor them for the cytogenic response, because at a lower doses, resistance quite often occur if you don't have a close cytogenic or molecular follow-up. If you just base our follow-up based on their hematologic response, it can predispose patients for resistance. So that's the issue or the challenge that we usually face. But we usually put these patients on lower doses of the TKIs. And in this particular patient, actually, when he was not able to tolerate 400 milligrams of imatinib, so the next measure that we took was putting on 300 milligrams. We put him on 300 milligrams for a few months, actually, but the cytopenia didn't show any sign of significant improvement. That's why we went to the treatment of nilotinib. Probably you could have started him, as you have rightly said, at a lower dose and possibly push into a full dose, but we tried him on lower dose of imatinib initially, Professor.
Okay. Thank you, Ephrem and Gianantonio. Just for the sake of time and making sure that we get to Ephrem's second case as well, I'll ask Ephrem to move on to case 2. I also can see that Fatu and Ahlam have questions about case 1. So keep your hands up and we'll come back to them straight away and with those points. But we'll Ephrem, if you want to present your second case quickly now, and then we'll come back for a discussion of both of them after.
Okay.
Thank you.
Okay. So I'll move to my second case, which is also about a young patient, which is female, 29 years old female patient that we diagnosed with CML, chronic phase 9 years back, and we put her on imatinib, 400 milligram daily. She achieved a complete hematologic response early, and she was adherent to therapy to 6 months. And unfortunately, despite proper counseling and regarding pregnancy and also the use of proper and strong contraceptive, patient was not willing, and she was young, and she actually got pregnant at 6 months of treatment. And we discontinued therapy by the first trimester of pregnancy. And once she was off treatment, she was lost actually from follow-up for a year. And after delivery, again, she was not able to come back to treatment because of economic and also social reasons. And she was lost actually for 2 years from treatment. And she came back after 2 years with symptoms of anemia and also progress with splenomegaly. And she had quite high white cell count and anemia. And after cytoreductive therapy, again, we restarted the imatinib treatment. And for around 2 years, we are not able to monitor this patient for cytogenic or molecular response. She had significant economic limitations, and the tests are not available were not available in our center. So we are just following her for hematologic response, which is quite suboptimal. But she was on complete hematologic response, and she was on follow-up. And she also reported that this mild chronic intolerance to imatinib, she had like intermittent headache, myalgia, arthralgia, peripheral tingling sensations were there. And actually, they were not picked during follow-up, and she had multiple treatment discontinuations because of this this non-hematologic intolerance symptom. And again, on top of that, she was coming from a very distant area from center, more than 600 kilometers. And because of transportation issues, again, she had multiple treatment discontinuations. And subsequently, then by the year 2022, she started to have leukocytosis, thrombocytosis. And we did the bone marrow. The patient was actually still in chronic phase. The blasts were less than 5%, but the BCR-ABL was very high. And this is despite the patient took the treatment properly for 6 months. The BCR-ABL was high. And we, with the impression of imatinib resistance because of the poor adherence that the patient had, we decided to see her at a higher dose of imatinib at 300 milligram BID. And she was able to achieve complete hematologic remission by 3rd month. Again, following that, she missed follow-up for a few times because of the similar reasons that I have mentioned. But despite that, she's still in chronic, she's still in complete hematologic response, and her cell count, the CBC is fine. And we are currently planning, we saw her last month, and we are planning to update the BCR-ABL to see where she is in terms of her cytogenic molecular response. And she is currently using hormonal contraceptive, and she's in hematologic response, but she has significant adherence issues because of the issues that I just mentioned. So there are some issues that I picked from this particular case. So there are some challenges in managing young CML patients. The population, the CML population group is quite different from what we see in the Western setup. She's young and treating like in terms of pregnancy and other young patients, they are head of the household, they have significant social and economic burdens, and they tend to discontinue treatment quite often. And that's a challenge in treating young patients with CML because of significant economic social limitations. And again, we cannot practice TFR in our patients because of a similar reason. We don't have in close cytogenic or molecular response, and we have only countable number of patients who were able to achieve TFR. Otherwise, it's very difficult to practice that for young reproductive age females in terms of advice regarding pregnancy and other patients. It's very difficult. And this patient also had some chronic tolerance to TKIs in terms of arthralgia, myalgia, features of peripheral neuropathy. And because of this, the patient's quality of life was actually quite compromised, and she discontinued treatment repeatedly. So these are the kind of things that we have to pick early while following patients over a long period of time, because quality of life can significantly be compromised by these issues. So these are some of the things that I want the audience to react to in terms of this case. Thank you. Professor, do you want to come into?
Ephrem, this case is a typical case of intolerance to imatinib. She was 29 at diagnosis, female. Yeah. And probably I referred before to some very large trials where quality of life has been investigated. One was carried out in Italy years ago on more or less 500 patients treated with imatinib, and quality of life properly investigated showed clearly how in young female population the quality of life is significantly worse with respect to other categories, young male and older patients. So in your case, clearly the chronic side effects led to bad adherence to the treatment, aggravated by the fact that this young lady, had problems to reach the referral center and so on. Clearly, you did your best, and now hoping that she will tolerate the treatment, but you know, we need to know if something better is behind the complete hematological response.
Yes.
The disease is 10 years now from original diagnosis, more or less.
Yeah.
So 10 years means, however, that air disease is not intrinsically running over an overblast crisis, because 10 years means that imatinib did something. Probably, if you have the occasion to pick up a qPCR test and is MR2 or something below, even lower dose of imatinib can accompany the patient along in the long term. You mentioned properly the difficult to face with the TFR in your country, but in this lady, my endpoint would be a good response, MR2, MMR, and then continuing in the long term imatinib. But the problem would be to let her tolerate. A question: you have assessed even to second generation TKI. Probably, if possible, to give low dose of nilotinib, no more than 400 milligrams daily, for example, or 50 milligrams of dasatinib, we can think to improve the adherence and even response. But low dose of nilotinib, not high dose, not 800 or even 400 milligrams daily is enough to. This is what I can say about this very difficult case, because sensitive but difficult to let the patient, to convince the patient to take the drug. And even in my experience, this type of chronic intolerance to imatinib, but even to other drugs, I have seen it mainly, if not only, in the very young patient population, below 30 years of age. Ephrem, have you the possibility to give nilotinib or low-dose nilotinib to?
It's possible, but in this patient, we thought that this patient has significant adherence issues. Initially, that's why she is not well respond to imatinib, and probably if we have a chance to try her at a higher dose, if she is able to be adherent to treatment, we could achieve at least a complete cytogenic response. And we're going to be doing the BCR-ABL, and if it is like above 1%, we'll be changing it to inotinib. That's what we are thinking at the moment. So we gave her significant adherence issues, and the economic issues are there, transportation issues are there. These things could be solved if we are able to decentralize same healthcare in our setup. This is the area that we require help from donations, from from different foundations. We are trying to currently decentralize CML care so that patients will be able to access treatment. We are training more and more hematologists from the countryside so that these things can be given while where the patients are. And it's quite a nightmare following patients with only hematologic response, not able to follow their molecular response. That's also something that's very much lacking, and we need support from different donors. That's what we are struggling with.
Thank you very much, Ephrem. I'm wondering if we can bring in the questions. I'm just looking at time. We've got about 5 minutes left for questions. And Fatou and Ahlam have been waiting very patiently. Fatou, would you like to come in with your question now?
Voilà, j'ai mis mon micro, j'ai activé mon micro. D'accord, merci beaucoup. Je voulais remercier Ephrem par rapport à ces deux présentations. Moi, je retiens que les problèmes qu'il pose sont les mêmes qu'ici au Sénégal. Par exemple, par rapport au premier cas, il se pose surtout le problème d'un suivi régulier. En général, c'est très difficile quand on a des malades qui habitent loin du centre de référence. Mais nous, on s'est organisé de telle sorte que avec WhatsApp, avec Internet, on peut avoir, avec le laboratoire sur place, au moins des numérations formules sanguines qui nous orientent vers une possible résistance ou une intolérance. Et là, on peut dire aux malades de diminuer les doses ou pas. Le deuxième problème qui est également commun à nous, c'est l'adaptation des doses. Il faut qu'on pense diminuer les doses chez des patients qui déjà d'emblée donnent des neutropénies. Quand ils vont présenter des neutropénies, l'idéal, c'est de diminuer rapidement les doses, sinon ça va être des sources d'arrêt du traitement et ça va répercuter sur les résultats de nos patients. Et puis le troisième problème, c'est comment faire pour que nous autres en Afrique, ici, qu'on puisse avoir des suivis réguliers, ne serait-ce que le jeune expert, pour pouvoir disposer de la PCR, avoir un taux de Besser-Abelson qui va nous dire est-ce on est sur le bon chemin ou pas. Dernier problème, c'est par rapport au karyotypage. Bien souvent, chez les malades, on ne regarde pas les anomalies chromosomiques surajoutées. Certains malades vont d'emblée être de mauvais pronostics parce qu'ils ont beaucoup d'anomalies chromosomiques surajoutées. C'est notre expérience. Je ne sais pas par rapport à vous, par rapport aux professeurs qui sont connectés, comment déjà faire disponibiliser ne serait-ce que la PCR ici pour rechercher le taux de Besser-Abelson résiduel pour pouvoir changer rapidement d'ITK, passer par exemple de l'imatinib au nilotinib ou au bosutinib. C'est essentiellement les gros problèmes que nous rencontrons tous à côté de l'association grossesse et leucémie myéloïde chronique, parce que la grossesse pose d'énormes soucis. Les patientes jeunes, d'habitude, ne sont pas adhérentes au traitement. La question que je voulais poser en même temps, est-ce qu'il était nécessaire d'arrêter carrément le Glivec ou est-ce qu'il fallait peut-être maintenir une petite dose résiduelle de 100 à 200 mg par jour en sachant que ça peut ne pas être délétère pour le fœtus, ne serait-ce que pour éviter les évolutions vers la transformation en leucémie aiguë. Merci beaucoup pour ces belles présentations.
Thank you, Fatou. And I'll hand back to Ephrem. Ephrem and Gianantonio, were you able to get the English translation?
Yeah.
Yes.
Thanks, Nicola, that because I heard only the last part of the comment.
Super.
But
And
two things I understood. One was related to additional chromosomal aberration and the treatment suggested after that. And a comment about the dose of imatinib of 200, which can be enough. As far as additional chromosomal aberration during the course of the disease, of course, I mean, is a long story because we must check which type of additional chromosomal aberration. But anyway, and in general, there is no evidence that in case of additional chromosomal aberration, changing from imatinib to a more potent drug then the clone with additional aberration will disappear, particularly if the additional chromosomal aberration is a dangerous one, like a double Philadelphia, like a deletion of additional chromosome 3, ISO 17q, and so on. If I kept properly the question. The second was a comment about the dose of imatinib 200 milligrams. If the patient is already responding and the tolerance of imatinib is a huge problem, you can try to go down to 200 milligrams. But 200 milligrams of imatinib are to be monitored more closely, because from the pharmacodynamic point of view, 200 milligrams of imatinib, you have part of the nose already under the water, okay? So efficacy is not reassured. I have a couple of patients on 200 of imatinib, but they were already in deep molecular response before. I don't know if I was able to answer to the at least in part.
Thank you, Gianantonio. We are at our scheduled time. I think we've got sorry, I'm just jumping in to say we're at our scheduled time, but we'll carry on our conversation for a few minutes more. If you have questions and there won't be time to ask them, please put them in the chat. And after the webinar, we will do what we can to get answers and responses to those questions and send them out to everybody who has participated today. I think from Fatou, there was the question about chromosomic anomalies and was it necessary to stop the Glivec, or would that have been possible to keep that going on a lower dose? Those were the two main points I picked up from Fatou's questions. But I'm wondering, Valentin, did you have any comments or responses to Fatou's question or Ephrem's cases in general?
No, I mean, these were very, very interesting clinical cases, and these are quite a problem that we commonly have to face. I fully agree with Gianantonio, according to, and the rest of the professor, according that once a patient has been on treatment for some years, I mean, the risk of progression is not very high. So we just need to give the patient the minimal dose in order to maintain the response. We know that we are not going to improve the response. We just need to maintain the minimal safety response, but the best quality of life. And that means that it's possible to diminish the dose.
Thank you, Valentin. Ahlan, would you like to ask your question very briefly?
Thank you very much. So thank you, Ephrem, for a great presentation. I do concur with you. We have similar conditions, just like how highlighted by Fatou. I wanted to bring to the attention for the first case in particular, the concept of benign ethnic neutropenia, which is commonly seen in African ancestry, where we see that even if the patients have low neutrophil count, around 0.5 to 1, they do not have increased risk of infection. So a question maybe to Ephrem, did the patient have increased risk of infection, as in recurrent admissions with infections? And also a question along the same line to Prof. Gianantonio. Would you consider in this case where the patient has had great molecular response, but having neutropenia, if it was proven that it was increasing his risk of infection, would you consider giving granulocyte colony stimulating factor as a supportive treatment rather than reducing the dose?
Thanks for the question. No, in that case, if the patient is responsive, I would suggest to adapt the dose of TKI. Common stimulating factor were used 15 years ago, at least, to try to overcome the chronic cytopenia, but linked to a resistance to TKI. So a very different situation, but they substantially failed. So you have to, I mean, even to understand why the patient is in chronic severe cytopenia being responsive. I'm thinking to maybe that in Africa, splenomegaly, independent from CML, is more frequent for previous infection, for example. A small splenomegaly can justify this type of chronic cytopenia because, once more, is not usual in patient responsive to a TKI. So maybe another reason. I asked to Ephrem about the weight of the patient, because if the patient is 40 kilos, 45, there is a relation, a mild relation, but it does exist between imatinib, hematological toxicity, and the weight of the patient. Since your experience is so different from mine, or in Europe, in Western countries, maybe there is another reason, I cannot understand why, to justify this excess of chronic cytopenia in patients responsive to TKI. I don't know if I was clear to my question was, my comment was enough clear.
That's fantastic. Thank you, Gianantonio. We are over time now, and I think time to draw our conversation to a close. Thank you so much, Gianantonio, Ephrem, for bringing your discussion, and also a very big thank you to Amma and to Valentin for their discussions before. It's been great to have so many people taking part and here to take part in the discussion. If you have any other questions that we have not been able to hear, or we don't have time to cover, please do put them in the chat. As I said before, Gianantonio has also very generously shared his email address if you wish to contact him directly. So please feel free to make a note of that. But we will leave it open for a moment for you to type your questions in for us to send to the panel after this evening's event. We're really hopeful that we will see you again for our next African regional discussion, which is happening in just under a month's time. That will be Wednesday, the 23rd of October. And we are going to be hearing from Dr. Matilda Ongondi and Professor Suzanne Sorzelle talking about TKI choice and sequencing of treatment in a world of increasing options. And also from Professor Noza Bazaway and Professor Naeem Chowdhury on the role of allo-SCT today. And then looking further ahead, on Wednesday, the 20th of November, the subsequent meeting of the regional discussion group discussing how do we get the best out of the CML laboratory, especially given the difficult task of meeting laboratory recommendations in low and middle income countries. And we're really looking forward to hearing from Professor Jerry Radic, Dr. Katerina Machova-Polakova, Dr. Alam Nasser, thank you for your questions today as well, and Assistant Professor Samuel Kinde. And those will be our up and coming discussions. So please make sure you are registered for those, and we are looking forward to seeing you there. And until then, please remember that you can also Stay in touch with us at the CML Foundation using our Knowledge Centre on our website. And there you will also be able to get CML news, up-to-date clinical case discussions, papers of the month, and also access all of the ICMLF programs and activities. So we look forward to seeing you there too. And if there are any other questions, please do feel free to put them in the chat or stay on briefly afterwards. But otherwise, I wish you all a very good evening. Thank you once again to our panel, and thank you to all of you for joining us today. Take care. Bye.
Thank you.
Take care.